So the challenge of pseudoprogression, you know, like I said, we have great difficulty distinguishing what's real and what's pseudo. And the modalities that we have at our disposal are PET scans, MR spectroscopy, and MR perfusion. And I'll cover those very quickly. PET scans. This is sugar. This is glucose. But we've substituted one of the fluorine 18 on one end. And that gives us radioactivity. And the radioactivity tells us where the glucose has gone. Where has the sugar gone? Where has the greatest metabolism gone? Tumors take up a lot of the metabolism in the body. That's why a lot of patients, when they get cancer, will become very, very skinny. They'll lose a lot of weight because the tumor basically soaks up all of the energy that the body absorbs. This is a PET scan here. And this is the patient that I just showed you. You can see that this area here has taken up a lot of the sugar. So that shows you, that's one clue for us that this is active tumor and not pseudoprogression. Pseudoprogression typically does not take up this FDG, this radioactive fluorine. This is a CAT scan. We have a PET CT scanner that tells us that yes, this does correlate with the area that we're looking at on the MRI. So this is MR spectroscopy, another tool that we use here. This is an interesting case because we have a lesion back here that's got nodular enhancement along the margins. So we're worried about this lesion. But if you look at the other one, you know, the enhancement's a little bit thinner. What we can do is we can place this box over this image and pull out actual molecules from the image itself. And as you can see here, these, let me just show you one more image here. This image, this graph here, it's actually a spectrum. It shows us a different, we call them metabolites, but they're different molecules that are in different concentrations within every one of these little boxes. And this box has this signature to it. This green box has this signature to it. So we can see that this is a tumor signature. It's called a tumor spectrum. And this box correlates with the front of this tumor here. But if you look at this mass up here, there really isn't that same kind of signature. So anteriorly, more in the front of the brain, you have radiation necrosis. And this mass back here is a real recurrence. And that was proven on surgery. Last, we have MR perfusion. And with the injection of contrast, every pixel on the image will get brighter and then it'll come down as the gadolinium washes out of your body. Okay? So you had a question about how fast does it wash out. It's pretty quick. You can, I mean, this is on the order of seconds, so it goes in and out. It'll be totally out of your body, you know, typically in half an hour. There's a certain, yeah. But through any particular tissue, through any one box on that image, we can map out that signal, and this time course gives us certain clues. We can get maps out of this, and so this area here, you can see is cold. So that means that there's not much blood flow in that area. That's not tumor, or that's not recurrence. However, here, on the same patient, you see down here that it's red. Okay, that means there's a lot of blood flow going through there. Tumors love blood flow. They recruit blood flow. They need that metabolism. They need that sugar. So you can see here that this area, this turned out to be recurrence. So this is, MR perfusion is another tool that we have. None of these tools are 100%. Okay? Even PET, which we thought was very specific, sometimes, unfortunately, the pseudoprogression will take up that sugar. We don't always know why.
One more question on
Yeah.
that. If with the perfusion, if an MRI is done with perfusion, then would it be more accurate, more an accurate reading if there is tumor progression? Why aren't most MRIs done with perfusion then?
Well, first of all, perfusion has to be done with a fast injection.
Okay.
So it's a larger IV. And most, are you talking about for all MRIs, or are you talking about for brain tumor patients?
I'm talking about brain tumor patients.
Okay.
Wouldn't it be?
Yes, we do that here. We try to get a larger IV into every patient here to do MR perfusion.
And so that way the blood flow it would give a more accurate reading if the blood flow is also measured than you see.
Correct.
Okay.
Correct.
Because they stopped doing the perfusion with my MRIs had always been done in the past with perfusion, and they stopped doing that. And I was concerned, about going to this new imaging center that the perfusion wasn't being used.
Okay. Well, we do it here. I'm not sure. Maybe they've thought you're stable for such a long time that it depends on the patients. Sometimes, for example, our techs will take a meningioma patient and do an MR perfusion because what's written on there is brain tumor. Now, meningiomas, I don't need a perfusion. You know what I'm saying? So it depends on the patient whether perfusion is really necessary or not. I also do spectroscopy on all follow-up patients as well. It just gives me more tools. PET scans are not done here. We have a sister facility called Shrewsbury Diagnostic Imaging, and that's where we do our PET scanning. Yes?
So what grade would you use a perfusion for? What grade?
Perfusion, oh, it's for most post-operative patients, any post-operative patient. So it doesn't, like that first case, if we want to go back to the WHO grade 2, that was a large tumor even though it was only grade 2, it was still taken out. Okay, so the other thing is that WHO grade 2s don't really enhance. So in those scenarios, it may not matter what kind of enhancement, because perfusion is really a super enhancement scan, if you want to look at it.
My husband has a low grade.
As a low grade.
Too.
Yeah.
So, but I don't believe they ever did a perfusion.
Right, because we don't expect that to enhance. So it probably wouldn't be necessary. Again, this goes back to tailoring the study for the particular patient. Yeah?
Bill, that's the radiologist call. It has nothing to do with the script that the doctor writes. The doctor has to, the MD prescribing this.
No, here, for all brain tumor follow-up, we'll do it.
All right, but let's say another hospital ordinarily would
Most of them don't.
It was on the script.
Correct.
Okay.
And some of them may not have the capability to do it.